Okay. This is a critical care in review related to extracorporeal therapies. So, I try to collect some data in the last 12 months, and I'm including, with the help of Dr. Venkat, one review article and two RCTs. So, one by one, we go through all. So, I'm starting with the Protect Duo trial, Protect Duo review article, which was published in Emergency Medical Technology and Innovation. So it is a Protect Duo percutaneous ventricular support system. It is basically a dual lumen device, but it's very different from the Avalon cannula, which normally we use in a VV ECMO. It is also inserted into the right internal jugular vein, but it is helping in the right ventricular failure. So I would like to introduce this device first, and then I will discuss about it in the next coming slides. So this is a picture which is showing the design of the Protect Duo. This is a dual lumen cannula, but it is having a typical configuration. In this, we have two versions of the device. One is the inflow and the second is the outflow. So we introduce this cannula with the fluoroscopy or ultrasound guided. And with the help of fluoroscopy, we always make a position of the inflow cannula into the right atrium, and the outflow cannula should be into the pulmonary artery. So intended position for the outflow cannula is the main pulmonary artery. So in this, the inflow cannula basically drain the venous drainage basically from the upper limb and the lower limb, and it relieve it into the main pulmonary artery. Basically, we are bypassing the right ventricle. So this cannula is very, very useful in the right ventricular failure. With the outflow in the main pulmonary artery, we can bypass the failing right ventricle, which will improve the pulmonary blood flow, and ultimately the left atrial LA filling pressure will increase and left ventricular pivot will also improve after this. So this cannula with the tandem heart pump are approved by the FDA as well as the European Medicine Evaluation Agency. So right heart failure, it is as we know that right heart failure is a right ventricular failure is a limited capacity because of the angiogenic response as compared to the left ventricle because it is a thin walled. But in cases with a right ventricular failure, where it is refracted to medical management, in these type of scenario, we always discuss about the mechanical circulatory support. So the primary goal of the mechanical circulatory support in the acute failure is to provide the adequate cardiac output or oxygen delivery to the organ which is actually into the stress or which is failing. And to achieve that, we have the options of ECMO or the surgical RV assist device or percutaneous right ventricular NCS, which is a new technology. So the Protect Duo was the first time used in 2016, and we got the result of Protect Duo after the 2 years of its use. But after that, there were multiple centers who are using this device very frequently. So what are the benefits of Protect Duo? It is minimally invasive, groin-free approach, which leads to easy early mobility of the patient. And there is no need of sternotomy, no need of surgical vascular access or the CPB during the implantation or the explanation process. But there is a theoretical concern about the Protect Duo that it can cause pulmonary edema or the pulmonary hemorrhage if flows are greater than what our left ventricular is able to tolerate. That is the only theoretical concern with the Protect Duo. Now, one by one, I will discuss about the multiple uses of Protect Duo. So, Protect Duo has been used for the right ventricular myocardial infarction with the RV failure. So, Kramer et al., they published the data about the 10 patients and they observed that 30 days mortality remained high at 40%. Although they have observed there is a favorable hemodynamic response after using the Protect Duo, but unfortunately, the mortality remained as high as 40% in his data. This is another use durable LVAD implantation. This is a very, very fearful and common complication after the LVAD implantation that sometimes the patient developed right ventricular failure. And we are still not prepared that we were thinking about the left ventricular failure, and after the implantation of LVAD, now we are dealing with the RVF, right ventricular failure. So Cruzeri et al., they successfully used this approach and they decannulated on 11th post-op day. There is a retrospective single center observational study. They have included 11 patients and they observed 90% of the patients were weaned from the temporary right ventricular MCS support. And the 30-day survival rate was 72%, which is very, very good results they have observed after this. But in the retrospective database review of 17 patients, they observed only 23% of patients successfully weaned from the right ventricular support. Including all these four, there are multiple published data is available and which is included in this review article. Maximum has shown a very good response after the Protect Duo, but somehow they could not get very good mortality benefit in few of the data. Now, this is another use of Protect Duo for the massive pulmonary embolism. Traditionally, we use VA ECMO whenever we are dealing with a pulmonary embolism. But some has published a case reports like they treated the patient of pulmonary embolism with a catheter-directed mechanical thrombectomy. But even after that, RV dysfunction did not improve. In these cases, they have used Protect Duo as a right ventricular mechanical circulatory support, and they have weaned the patient successfully in 48 hours. And the notable advantage of Protect Duo was, as compared to the VA ECMO, even with the Impella RP, that you can use this even with the IVC filter in place. So this was the additional advantage. If we are using Protect Duo for the massive pulmonary embolism, the patients are having right ventricular failure, this is a very, very advisable device. Now, the Protect Duo in cases of heart transplantation, sometimes we are having the primary graft dysfunction, which is a common complication after the heart transplant and affecting almost 2 to 28% of transplanted patient. But and this is the most common cause of early death after the heart transplant. But sometimes up to 45 of the patients, if the dysfunction is because of the right ventricular failure only, so we can take the help of Protect Duo rather than putting the patient on VA ECMO, which can have very unnatural blood flow direction and which can have venous congestion that can cause to pulmonary artery thrombosis. These are the additional complications when we are putting the patient on VA ECMO in a post-heart transplant patient. If we know, sorry.
Dr. Fatima, in view of limited time, we'll take comments.
Sure.
So this actually, the cannula talks about this can bypass the right ventricle.
Yeah.
And when it is used with HeartMate or a CentriMac, without an oxygenator, we use it as a right RVAD, right ventricular assisting device. If we use with a oxygenator, we use as a venopulmonary ECMO. So that's a wide spectrum of indication what he mentioned, the right-sided ventricular infarctions, right heart failure with other reasons, post-cardiotomy or post-cardiac surgeries. So we will take comments on this. This can be used as a bypass of right ventricular. It's clinical use and what is the current status. We'll take Dr. Arpan's opinion on that. Dr. Arpan, can you be on board?
Yeah, so this is probably out of the three papers what you have chosen, this is one of the positive paper. A positive device came out in 2023. It has been in the air for last 2-3 years, where we are actually struggling with long VV ECMO runs, which is leading to a secondary RV failure. And we don't know what to use. Because after 45 days, you have seen that, we have all seen that VV ECMO, higher flows are bound to injure the RV, and RV is getting dilated, your anti-probenp is up, it is up, increasing day by day, and your TAPC is going down. So what was the answer to that? Pritama has not mentioned that Maybauer's paper, which is the most important part, where he has used this during the COVID, this kind of long ECMO runs, where we have seen a lot of RV dysfunctions in presence of ARDS. So Protect Duo actually scores over on that situations where we have, or he has able to bypass the VA requirement of VA ECMO and somehow not touch any arterial support. So that is the area. Prolonged VV ECMO with an RV failure, impending RV failure, is the main part where Protect Duo is helping us who are using regular basis, who is doing the regular ECMOs. Now, another thing is the most important, that is, it's a kind of bridge to RVAD. Till now, we have no thing other than putting on VA ECMO. What is to done with the RV? It can be the secondary to the LVAD or secondary to transplant, whatever may be the cause. What you have to do with the RV? Then everybody have asked, put this kind of patients in VA ECMO and wait. But nowadays we are not doing that, and Protect Duo might be helpful on that. The problem is with the Protect Duo, obviously, what Pritama has told, that if your LV is not performing well, or it is not handling a good number of blood flow, then Protect Duo will be a superfluous addition to your heart, because it can supply 4 to 5 liters of blood, where if your LV is not able to handle that amount of blood, is a problem. What we're talking about, that after heart transplant or after LV assist device, you should be sure how much flow should be given to the Protect Duo. That is the most important part, because LV might not be able to handle that kind of PA flow or pulmonary arterial flow.
The Protect Dio generally gives a 2 to 4 liters of cardiac output, which it can. So, what is your recommendation? You need to titrate according to your LV function.
Yes. We have to be damn sure that LV is fine. Number one, it's a pure RV support. You cannot get though people are using sometimes to get the Impella and all these things, but it's a pure RV support. It has not proven any benefit when the LV is not doing well. So you have to be very cautious. So flow has to be titrated as your lactate and other things, and with the LV, how is the LV is taking? Because what we have seen that in RV failure, this position of the septum is most important. So if you are after putting Protect Duo, if your RV overload is not managed, then you are in the same problem. So that is the thing what we have to keep in mind. And
Any
obviously,
comments?
the migration
Any
of
comments
Protect Duo.
on that? Exactly.
Yeah, migration of those who have used the migration, there is always a chance of migration, because once you put them on ECMO and all these things, these PAs get softened out, and the cannula started migrating to the one of the pulmonary artery. The second pulmonary artery doesn't get blood. That is one of the problems. And obviously, the position always kind of changing things are there. So nowadays, people are using a inferior vena cava, your femoral venous drainage with Protect Duo. Sometimes that's a VVP combination actually, because to counteract on that, this migration kind of thing.
So the important highlights at this point of time is it can be a device where Dr. Arpan is emphasizing in a prolonged VV ECMO patient where they land in RV dysfunction and you have no rescue but to switch to a VA ECMO earlier. Now we have a device which can bypass RV and help you on. You pointed out that the device has to be in position and you need to be sure about your LV function. If your LV function is suboptimal, you need to titrate your probably flow, or you may need another device to support your LVAD in other way. So that's the take. So Pritima, in the view of time, we will move to the next talk. Thank you, Dr. Arpan. That was an excellent overview. We happen to use this device for a RV infarct patient. That's where I was discussing with Pritima. This can be a device we look for.
So can I ask one question here, sir? If you don't mind. Yeah. So, Dr. Arpan, as Dr. Venkat just mentioned that we can go to 2 to 3 liter of the flow to the Protect Duo. If our LV is good and we are considering that this device in cases of pulmonary embolism, suppose, because right failure and we just want to empty the right ventricle, is there any criteria to decide about the flow, that this much flow we have to give, or we can just adjust? If our cannula can take over 4 liter of flow, can we go up to that?
No, in case of pulmonary embolism, you can go up to 4.5 liter of flow, whatever you want. I'm telling about when see the problems what we get, this kind of infarct, post-infarct cases, it is usually a biventricular dysfunction. Sometimes you are not very much sure that what is happening to whom. So you have to titrate and looking at the position of the septum so that the LV input, LV the output should not get hampered. So I will tell you to get, it's a kind of trial and error method. Start with 2 liters or start with 4 liters, then you come down, or start with 2 liters, go up on that.
Okay. I think it's clear, sir. We'll go to the next
Okay.
case.
So we are going to the next original research article. It is a extracorporeal membrane oxygenation in the therapy of cardiogenic shock. It is a result of ECMO cardiogenic shock randomized clinical trial. So it is a randomized investigator-initiated trial. So in this, they have included total 122 patients, and out of which they divided into the just a second, my slides are not moving. It's yeah. So they included the patients who fulfill the criteria of severe cardiogenic shock, rapidly deteriorating cardiogenic shock, best correspond to the SAI stage D or E. So they should include the criteria of hemodynamic, metabolic, as well as the echocardiographic diagnostic for the severe cardiogenic shock. So they included these patients and excluded the patients of less than 18 years of age or having some chronic condition, underlying chronic condition. So they excluded a few patients. But based on these inclusion criteria, they divided into the two arms. One is the early VA ECMO support to the cardiogenic shock, and one is the therapy. I'm not getting the word. That
Not so early.
Conservative.
yes, rescue
Not
therapies.
so early.
So they compared the baseline characteristics were similar in both the arms, and the incidence of composite primary endpoint and the individual composite primary endpoint and the secondary composite outcome. So they could not find any significant difference between both the conservative as well as the VA ECMO support. And and this is the diagram which is showing it is the comparable graph in both the groups. And when we see about the adverse effect, so they have observed almost similar adverse effect in both the groups, including pneumonia, sepsis, technical complication, but they have seen more chances of leg ischemia, stroke, and bleeding in the VA ECMO group. That is also not very significant, but yes, there was little higher on the VA ECMO side. And after this trial, they concluded that immediate implementation of VA ECMO in the patient with rapidly deteriorating or the severe cardiogenic shock was feasible, but they did not improve the clinical outcome as compared to the early conservative approach, which permit the downstream use of the VA ECMO in the cases of hemodynamic worsening. So I think, and these are the ongoing trials on the same thing.
Yeah, I think these trials may give you a little more light, but a few points I wanted to highlight here. They spoke about very rapidly deteriorating cardiogenic shock with probably a refractory cardiogenic shock, and difference between that to a cardiometabolic syndromes, which we are now talking about. And you actually missed a point where there is a 39% of crossover from one group to other by adding a VA ECMO in them. So, first of all, Rahul Pandit sir, how you will take this trial? We all understand that a refractory, rapidly deteriorating cardiogenic shock, VA ECMO is the choice at this point of time. And now this trial gives you that you first trial, you can have a conservative method and then you can switch to a VA ECMO if needed.
I think Dr. Venkat, you actually rightly pointed out that there was a 39% crossover between the two trials. So if you look statistically, the fragility of this trial, the fragility index of this trial is very, very low. That means a few patients here and there, those 5 patients which they did not take into account because of lack of consent, actually would have made a difference in the outcome had those been counted up into the group in which they were actually added. That was one point. They don't talk which group the 5 patients were removed from. That is another problem. Whether it was the therapy group or it was the conservative arm group, which we don't know as well. Now, it does give you a signal that when you have a rapidly deteriorating patient who is rapidly worsening and going into a multi-organ failure, the clinical indications also, common sense also tells you that essentially they are the ones who are unlikely to be salvaged, despite whatever you do. Whereas when those patients you are able to salvage initially with medical management, and then despite your reasonable amount of resuscitation down the track, you put them on mechanical circulatory support for a definitive therapy, obviously those patients might have a slightly better outcome. That is the whole premises of thought process behind this. But I really don't think that this trial is giving us any answer. I would still be very, very skeptical about saying that this patient is worsening and I'm not going to do anything for this patient because the trial did not show any good outcome. I believe that we should be able to still push across and put these patients on mechanical circulatory device vis-a-vis ECMO, and do the definitive therapy. The definitive therapy is the main problem here. They do not go and mention about have they actually gone across and fixed the problem. So cardiogenic shock, just support, or did they go? I read the paper, Pritima, but correct me if I missed out anything. Did they go across and do any angioplasties? Did they go across and do actually the
No.
correction of the problem? They have not mentioned
No,
that.
no,
They're not mentioned about them. There
Yeah,
must
not
be
mentioned,
something here.
but
There is no mention about the interventions to correct the cardiogenic shock.
correct. That's
Reverse
precisely
the
my
cardiogenic.
problem. That's precisely my concern. That what have they done with that? Have they just stabilized, and then when was the intervention planned? So the intervention was also appropriate, and the therapy given in both the groups was also clear, also equal. Then this trial forms some importance to me. That despite doing a conservative versus aggressive ECMO and giving both the groups the therapy which was required, still the outcome were equivocal. Then I believe that this trial has got some merit. Otherwise, this trial just gives you a signal. It doesn't actually give you anything more than a signal right now. I think the Euro shock is a much bigger trial, and the ECLS shock is a much bigger trial. That should give us an answer of whether the early intervention with a VA ECMO does make a difference in cardiogenic shock or not.
Yeah, there is again another additional problem in this, sir. Both the arms have received some other mechanical supporting devices
Correct.
uh,
yes.
close to 20% of the
Up to
time. So we
30.
don't know what those mechanical supporting devices, what was their role played in this results also. So any
Yes.
points from Dr. Arpan on this trial?
Yeah, this trial actually reminds me of Eolia,
Okay.
because where the crossover is the most important rather than the actual outcome. The crossover, again the Eolia also, we
Yes.
tried on this crossover. We didn't treated the on VV ECMO at that point of time, and then ultimately we have to give on VV ECMO to those who are hypoxic, less than PF ratio of less than 100. So crossover is the most important. As Dr. Pandit also pointed out, the procedure they have not done, what they have done for angioplasty or a CABG or something else, they have not done. So it's
Okay.
it's a shocker for us in 2023.
नहीं अर्पण भाई कैसा है मालूम है अर्पण if you add those 5 patients in one group now the entire
Then
Yeah,
group
it
will
would
change.
it could
Because
have
we are
been
adding
changed.
10% patients to one group, 10% in one group. Because it's only 122 patient trial. You
yeah,
add
yeah,
more
very
patients
very
to one
small,
group,
very small.
the whole picture will become statistically significant suddenly. And the information given is very sketchy. They haven't told which group the patients were not analyzed. They haven't told why the crossover happened and which devices were used as an additional circulatory device. And then the most important question, they haven't talked about therapy, whether the therapy given to both the groups was equal or not. Now, I don't think ECMO as a therapy. I see ECMO as a support. All
Bridge.
see ECMO as a support just to facilitate therapy. If you're not going to give therapy after ECMO, I think we are wasting time. Then we should not be putting them on ECMO. The
Sure,
whole
sure.
purpose of putting somebody on ECMO is that we make the therapy as safe as possible, whether that's a CABG, angiography, angioplasty, whatever it is.
I think it's as you rightly said, it is a bridge to either a recovery, either a bridge to a transplant, or a bridge to some procedure.
Correct.
And when we talk about bridge to recovery, maybe without any procedures like myocarditis, cardiomyopathies, with some things where they are refractory, there may be a possibility. But other situation, as you said, ACS, they need an intervention. They need a repair if there is a problem.
Yes.
I think wait for Euroshock.
Okay.
I think
They're
Euroshock is
still
a much
And
better
recruiting.
designed
I
as well.
also didn't
They're
understand
still
that
recruiting.
initial even randomization, the lines rapidly deteriorating hemodynamic patient categorizing in one to VA ECMO, the other to conservative management, and then switching them to this. So somebody who is rapidly deteriorating hemodynamics, and then you are going for a conservative. I actually the whole line itself was a little
Thing is not.
confusing when I read.
But
I'll
it
tell
looks
you,
like you are not giving CPR after cardiac arrest, and you are waiting that what will happen, not giving CPR to arrested victim.
And
I'll tell you, this seems to be a trial designed by a ECMO believer who wanted ECMO to be available for both the groups. That's the first. So whoever has designed this trial is an ECMO believer. which is fine. I mean, you always will have people who are believers who would design a trial. The second problem is that rapidly deteriorating, requiring boluses of vasopressors. That's one of the
Vasopressors.
other words which they have used. It's
Yeah.
all funny. That means that you are only doing it, you are doing quite a lot during CPR. So it's almost like you are doing eCPR there.
And then they have divided the randomization. After
Yeah.
that, the randomization happened.
Yes.
Right, you are right.
Any comments on cardiometabolic syndromes? Because we are talking about cardiogenic shock differing from cardiometabolic syndrome, where you have a metabolic changes, lactatemia, organ dysfunction, just not hypotension or cardiac dysfunction, leading to metabolic syndromes.
Cardiometabolic syndrome, I think we need support. We definitely need extracorporeal support. Now, it is debatable which extracorporeal support you would need, would depend on the etiology. So, for example, if it's an acute coronary syndrome, you've got Impella, which is a very, very good device which can actually help you during the procedure, as well as it can serve as a bridge for some time as well. VA ECMO, obviously, you can do. I have had mixed experience with VA ECMO when you do it for acute cardiogenic shock. And some of them have been related to the complications which Pritima mentioned in this paper as well, bleeding, limb ischemia, so on and so forth. I think I saw Dr. Mure on call as well. He's our cardiac surgeon and our extracorporeal mechanical support in cardiac surgery director and our transplant surgeon. They do a very nice axillary conduit. Are you there, Dr. Mure? And they do a very nice axillary conduit, and it very nicely helps to sort of conserve the limb ischemia part. It completely takes it out of the picture. Arpan, do you do axillary conduit in your institute or Venkat?
No,
Not so common, sir. Not so common. We do take femorals mostly.
sir.
When
Unless
surgeons do, they do
unless-
always axillary conduit because it's a kind of antegrade flow they give, and it
Yeah.
is better suited for them.
Yes.
And as you rightly pointed out, Impella, less invasive, easy device for a short procedures, like you want an hour or two during your coronaries to be opened and all, and then after 6 hours a day, pull it out. So less invasive than VA. We'll move to the last paper.
Yeah,
Dr.
I think
Pratima.
Dr. Venkat, Dr. Mule wants to comment on it. Dr.
Yeah,
Mule,
please go ahead, sir.
he unmute himself. Yeah.
No, I don't have any comments on there.
Okay. Okay. Thank you, sir. So moving on to the third trial. Yeah. So this is a recent trial which I think is out in December itself. It's a prone positioning during sorry, extracorporeal membrane oxygenation with a patient with severe ARDS. It's pro-ECMO randomized clinical trial. So this is when I think prone concept comes after the ProSeva trial, when they tried for 16 hours proning and they observed that 90% mortality benefit. And objective for this is to test the whether prone positioning versus supine position, if it decrease the time to successful weaning from the ECMO in the patient with severe ARDS who are supported by the VV ECMO. So the design was again the randomized clinical trial, and in this, they included 250 patients with a severe ARDS undergoing VV ECMO and assessed for eligibility. And after the eligibility testing, they excluded 80 patients out of it. And finally, 170 randomized to two equal group. So 86 prone positioning during ECMO and 84 supine positioning during ECMO. And then they included these patients for the primary analysis. So this is the, and when we compare the baseline characteristics of both the groups, there was no significant difference. It was quite comparable group. But if you go to the primary and secondary endpoints and the adverse events, so again, for the considering primary outcome, which is successful ECMO weaning by the day 60, and competing events, death before ECMO weaning failure. So these are the comparable group if we talk about the primary outcome as well as the competing events of the primary outcome. And addition to it, if you compare the secondary outcome in the both the group, prone and supine group, so that also comparable as compared as we talk about the all cause day, 60 days mortality, 90 days mortality, respiratory system compliance, and even with the other organ failure like kidney failure, cardiovascular failure. So this was quite comparable group in this trial. And if we compare the adverse event, there was only one adverse event which was more prone in the supine patients, which is the increasing chances of cardiac arrest. So they observed more cardiac arrest episodes in the supine ECMO group. Other than that, if we compare the adverse event, both the groups were comparable. This is the graph which is showing it is a quite comparable. If we talk about the weaning failure, so weaning failure is defined as the need for second extracorporeal support or lung transplant or death within the 30 days after the ECMO decannulation or discontinuation. So these patients which has been decannulated or discontinuation in the ECMO group, 8 out of ECMO group and the 2 out of supine group were weaned from the ECMO but died within 30 days after the ECMO discontinuation. But one patient in each group needed a second ECMO support within 30 days after the ECMO discontinuation, and none had a lung transplant in these groups. If we talk about the limitation of this trial, the sample size may have been insufficient to detect a clinical meaningful treatment. Addition to that, the sample size was less, and at that point of time, in the ARDS patients, hardly the 7% patients were considered for the VV ECMO. And it has a limited generalizability because they have included almost 70 patients out of 120 patients from the one single center. So they have a doubtful generalizability of this trial. And the trial was unblinded due to the nature of intervention, and this design may introduce bias in this trial. So I think to conclude this trial among the patients with severe ARDS, which is supported by the VV ECMO, so the prone positioning during ECMO did not significantly reduce time to successful weaning of ECMO, although there was additional benefit of proning when the patient was on ECMO. There was a good gas exchange they have observed. They have observed the hemodynamic stability after the VV ECMO, but still they could not observe any successful weaning or significant time of weaning from the ECMO.
Um,
Yes, sir.
thank you, Dr. Pratima, for this trial. So the interesting part is both the groups received the same base ventilation, and all these cases are post-COVID. And interesting is 96% of them received proning before this process of ECMO. So almost everybody received proning before this. So with these two comments, I will take Dr. Muni's opinion. So the prone has been a normal phenomenon for all ARDS patients on mechanical ventilation. We try to extrapolate it with the VV ECMO to recruit those posterior segments of lung to actually make them quicker to wean out of ECMO. But this trial has actually rebounced back. So what is your take from this, sir?
So, well, yes, sir. Thank you, Pritima, and thank you, sir. Nicely explained by Pritima, and you highlighted one of the most important point here. Well, we were looking forward for this trial, and we were quite eager that it might show something which makes sense. If it's working pre-ECMO, if it's working in ARDS when we are not considering ECMO in that era, so it should very well work in after ECMO also. So that was the thought behind this, and that was what we were looking for. But yes, it was a bit of a disappointment. But as you said, one of the biggest flaw was that most of the patients are COVID. I believe upwards of 90% patients were COVID. And what we have been led to believe, though data will still keep on coming, is that COVID patients behave a bit differently than non-COVID patients, lung-wise or otherwise, pulmonary or extrapulmonary. And plus, you cannot take away proning from the protocol. So you cannot say that I want to do a study, so I want prone him, I will put him directly on ECMO. So that limitation is there. So if the patient has not responded to prone ventilation before ECMO, that's why the patient is on ECMO. So to expect that he would or she would respond to ECMO as to proning might be one of the biggest flaw here. The other thing that we have been a center and who are bit bent toward awake, keeping the patient awake on ECMO, spontaneous ventilation on ECMO. Pritima has been a part of it few years back. So there's a lot of data that says, okay, awake, spontaneously breathing patients do better oxygenation wise. Now here we are talking about a modality which we sedate them, we paralyze them, and when we prone them, and then we prone them. So this is one aspect which needs to be touched in future studies, because we are going against one fundamental of awake patients, awake ECMOs, and spontaneously breathing patients, and paralyzing them and sedating them. So that is the aspect that is there. Now, when we talked about proning initially, the first thought was to prone patients who were not being weaned off, long runs, okay, you want to wean them, or who are not being oxygenated despite maximal flows, okay, who are hypoxic or ECMO. Here in the study, these criteria are not being kept. They are just proning everyone. Okay, there's a 1:1 rational, there's a randomization, and every patient is being proned. So another, this is another flaw that comes springs to my mind, that why we proning every patient? Why not target those patients who are not are still hypoxic on ECMO or are having weaning difficulties? So this is one thing, and another last point that again springs to my mind is that, does improved oxygenation really lead to a mortality benefit? There's no data to suggest. We do think that, okay, if I improve the oxygenation, my mortality will improve, but still nothing definite can be said about that. So my belief would be that obviously numbers is an issue. There have been retrospective observational studies, anecdotal case reports who say that proning is better, but this is an RCT and first of its kind. So my take would be that rather than proning everyone, studying proning in every patient, we should have set criteria. I don't have an answer to that. What criteria? But maybe CT guided criteria. Patients who are not able to maintain spontaneous ventilation or are hypoxic on even on maximal flows. I think we should work out a study in which these are the inclusion criteria rather than generalizations.
So, Dr.
That,
Munish, you are trying to point out not all patients may get benefited by proning in an ECMO patient. Maybe a subset of patients who had a recruitable posterior segment of lungs, which gets ventilated and opened up, recruiting by a proning, aerating them better, maybe a segment which may have a benefit.
exactly.
Again, taking the risk against the securing the cannula, the complications related versus the benefit which we get out of it. There is some interesting data in the trial. The cardiac arrests were 11 in the supine group, 3 in the prone group, but there is no difference in the mortality and outcome. Something the patients revived after that cardiac arrest. Uh,
Even
the
they've not mentioned actually why. Matlab, they've not tried to defend or give an explanation for that. That why cardiac arrest was higher in the supine position. So can't don't know. Matlab, so number is too small. Might be related to the patient disease itself, but there is no explanation why that should happen.
and you take that point ki the complication rates in both are same. There was no cannula displacements, no
You,
bleeds, no pressure.
if can go to the previous slide, the second limitation is no generalization. Now, most of the data comes from a center which is very experienced in proning and ECMO. So we are talking about a center which is the most experienced center. If you see the second point, and this is a center who have been doing ECMO, who have been doing proning. So it's very difficult to extrapolate to another center who might be facing greater number of complications because of the experience. So limited generalizability is another problem, sir.
Any comment from Dr. Arpan or Dr. Pandit? Are you around?
Yeah,
I
I'm there.
think
Sorry, Arpan, you go ahead. You go ahead first.
okay. I think this is a very interesting study, and we are all waiting for this study
Yeah, I
results.
agree.
But it didn't came out well with us. But believe me, the proning on ECMO we have learned during COVID. We have not done earlier. We
Exactly.
have not done earlier, and a few category of patients that effect was marvelous. And obviously that has not extrapolated in the proper outcome, and few of them obviously not did well, that we have seen, and but few of them it has worked. So now the phenotype has to be identified, whom to prone,
Exactly.
whom to prone.
Exactly.
I
Who to
think
So
prone?
do you
that
think
Absolutely.
phenotype has to be identified,
you think
otherwise
a CT scan will
it is
give
of
you
no
some
use.
idea? A CT film will give you some idea in phenotyping the posterior segment being involved, basal segment being in collapse state. Is that the way you take it, or how do you actually take it?
Basically, an idea of recruitability will with CT scan, I know electronic impedance tomography. This might give an idea. What do you say, Arpanda?
I think so. I think so. Actually, in the second wave, the duration of the study is in the second wave, and where we lost lot of patients due to this rupture of this thing, either pneumothorax or pneumomediastinum has happened. Lot of things. So those things are hampered on that to prevent those kind of recruiting exercises. So that was the problem, because we have forgotten to give a PEEP more than 8 in this kind of patients. Earlier, we used to use 14 peep, 16 peep. Now we are using 6 peep, 8 peep, this kind of patients, just to prevent those kind of pneumothoraxes. So very difficult to do the recruiting exercises at that point of time. And obviously, the CT scan might be of some value. The posterior consolidations were better to prone and all these things. But I seriously don't know which patient to prone and which patient.
Few lines on what precautions you take. See, proning on an ECMO patient with securing the lines, having a nursing ratios, a few words or few lines on this, the measures you take for proning.
Proning, the measures, obviously, I have seen the 6 people are required at that point of time. We'll take care of the lines, especially if the necklines is there. That is the most treacherous point. And obviously, if you have tracheostomy, it is getting more difficult rather than having a endotracheal tube, because it is very difficult to get that thing to be accommodated during proning. That is one cause. And second one is the hemodynamic instability sometimes happen, and the flow fluctuations. Sometimes it has happened that you are prone and flow fluctuation has started, you made him supine. So that is one of the cannula migration. That is one or two concerns we have. But otherwise, it is not that unsafe to prone them on ECMO. It is better to prone after ECMO rather than sometimes it is difficult pre-ECMO proning.
And sometimes that abdominal pressure, if the abdomen is not free, the venous return does go down. It goes down. I agree.
Rahul sir,
think,
any final
yeah,
comment?
look, I think ECMO proning are two different things. Again, we've got to split them together, split them differently. ECMO, as we all know, is just basically a conduit for us to get better, whereas proning has actually shown improvement in the outcome. So I think we should be trying out ECMO and proning together if we can try that out together. Now, I know the evidence is very sketchy right now, but physiologically and principally, it makes a very good sense to do it. If you can emulate ProSeva trial on an ECMO, it should probably have better outcomes. And that's why these trials are being conceived. Secondly, how to prone, as Arpan said, 6 to 8 people are required. We have been using the envelope technique, which was described in the NEGM, where we actually wrap the patient between the two sheets and we just flip them over with 2 people dedicatedly looking at the lines only. And that's a very easy technique. With that, we actually learned the envelope technique when we were proning these patients in COVID. And I have seen that even young, thin-built nurses are easily able to flip the patient across with the envelope technique, even a big-built boy or a big-built person. And thirdly, as he rightly said, cannula migration and dropping of flows is very notorious if your abdominal position is not correct. If you've kept your abdomen free and there are no pressures on the probe, you will never have a problem with the flows. And when you actually prone them, don't try to keep these patients on a negative fluid balance. Keep them euvolemic, keep them adequately filled. Once you have proned them and established a reasonable amount of hemodynamic stability, then you may think of taking off some fluid. But if you prone them hypovolemically, trust me, you will have a very big problem, because as soon as the intrathoracic and the intraabdominal pressure rises, the cannula sort of starts collapse, the vein starts to collapse around the cannula, and your outflow cannula becomes a problem, and that will start dropping pressures and it will start sucking very hard. So these are some of the few tips which we can do. But I personally feel physiologically it makes a lot of sense to prone patients with severe ARDS on ECMO.
So you're basically trying to say the ECMO is a bridge to recovery, but you need other physiological measures to make the lung better.
Yes.
ECMO can't help to make the lung better. It is only rests the lung. It does that alternative work, but you need a the recruitable part, open up that, make the lung better so that you can come out of the ECMO. So
Correct.
you have two different segments. One is support. The other one is you're helping the patient to come out.
Yeah. And so, yeah, I completely agree. That is my principle, that you need something to actually help you recover. And ECMO is just a bridge. It is not going to help you recover. What ECMO does, it prevents the harmful ventilation. So you can actually tone down your ventilation. That's one thing which ECMO does. What does prone do? Prone helps us to recruit organs better, the electric lung better. It helps to clear the secretions. One question which my colleague has asked, Tushar has asked, should we ventilate conventionally if ECMO with prone, which actually is Proceva and ECMO? I think you would find that in many patients, you are not able to tone down the ventilation completely down. So as we, I would have loved to have a PEEP of 5 or less, but it's very difficult to keep them on a PEEP of 5 or less. They are significantly hypoxic despite being on high FiO2 and ECMO. So I think the whole idea of giving a very ultra protective lung ventilation on ECMO is not true with these hypoxic patients. You still need to ventilate them a little bit. And I agree with Tushar, you need to ventilate them with lung protective ventilation, what we would normally do. I would keep the plateau pressure below 27, definitely. I would keep the pressures as narrow as I can in terms of your
Right.
ventilation and continue with the proning. The driving pressure should be as narrow as possible.
Yeah, I think we, with the limitation of time, we had crossed the 3 trials and 1 review paper, 2 trials and 1 review paper. I think we thank all the 3 for sharing your experience, your wisdom.
Dr. Venkat,
Yeah.
sorry, I would like to ask you, as Dr. Pandit said that he would like to prone severe ARDS patient on VV ECMO. That means that every ECMO which we have decided ECMO to recovery, so sir would like to prone those patients. What is your take? How you decide about the patient that I want to prone this patient on ECMO? Is there any specific criteria you take, or like Dr. Pandit said, that I would like to prone all the patient bridge to recovery?
See, what happened in this particular trial also, I was trying to emphasize that if you actually put ECMO for a patient who has already been ventilated for a week and prone for a week and you are already delayed, so you're in a stage from a regular proliferative to proliferative fibroproliferative stage. So we all know those are the patients in many of those, the wave, second wave of COVID, where no proning was helping there. They are all delayed patients. But if you're talking about a patient who you actually initiated an ECMO in the early part of your ARDS, where they were hypoxic in the day 1 or a day 2, not able to ventilate them in a safer way, you're crossing your limits, and you know there is a recruitable lung, I will prone. But yes, it is a labor intense, you need a team for that, you need an expert center for that, or if you are not, you need to learn about it. As Dr. Arpan said, you need that protective gear. See, cannula displacement is not uncommon, and it can just catastrophically kill your patient. Your nursing ratios should be adequate, your training should be adequate. Dr. Arpan, Dr. Rahul Pandit and me all work in a center where there's a large volume of patients of ECMO and the teams are trained, but it cannot be extrapolated as the same point which is stated, generalizability. The same thing cannot be generalized in other centers. That's my point. Any take from Dr. Arpan or Dr. Munish in that?
Yeah.
Yeah, I agree, sir. As I said, that one other thing that I would take the lack of complications with a pinch of salt is that you are talking about a very experienced center. And if we, dispense this with confidence that everyone should do it, we would be ending up with a lot of more complications. Because right now, a lot of centers don't even do proning without ECMO. And we are talking about pushing it to centers with ECMO. So you need a lot of labor-intensive commitment here. So I think and that's what the one of the flaws is, because this is, though it is a multi-centric trial, but a major chunk is from one center only.
My center, actually, Dr. Sri Charan heads that unit of ECMO. There is a dedicated ECMO physician. He loves to prone patients if there is a recruitable lung. He was very disappointed with this trial. Dr. Arpan was also there. He
We are
interacts
also
with him.
disappointed.
Dr. Arpan, your take on that, the last take. Dr. Pritima wanted, what do you do? Do all patients be
No,
prone?
no, no. My take on proning is on ECMO is when the patient is not adequately oxygenated on ECMO, the saturation is less than 85. That is the point I prone the patients. Otherwise, I don't do normally.
I would
Okay.
say only three groups, three indications: CT scan giving a phenotype, hypoxia on maximal flows of ECMO, and if you are not able to, go for awake and spontaneous ventilation on ECMO. I think these should be three groups.
I think Dr. Mule want to comment something. Yeah, yes, Dr. Mule.
Yeah, Pritam, I think the discussion, I enjoyed the discussion. I have published a paper in Indian Journal of Heart Surgery in 2022 uh, about our experience in mechanical circuit support. What I understood while writing that is that patient A is not same as patient B, and it is very difficult to do a randomized trial in patients in whom we do mechanical circuitry support. It is not planned thing. It is always an emergency thing. And which we choose, which cannulation we choose, which mode we choose, whether I choose ECMO or I decide to put an without an ECMO. So whether the lung involvement is there or right ventricle is involved or only left ventricle is involved, like in cardiogenic shock. If it is for the lung, it is very clear. It is VA ECMO or VV ECMO. That is different thing altogether. But along with this, if you have got patient in pulmonary edema as well as in cardiogenic shock, then my point is we have to consider the comorbidity, we have to consider the present situation, we have to consider the availability of the things at that time, we have to consider the expertise at the thing of the people who is there at that site when patient is in cardiogenic shock. It is not a planned thing. Every time I cannot take the patient to the operation theater and do my cannulations or a central cannulation or axillary cannulation, and then I have to tide over the crisis. Then the plan can be weaned off from a machine to another machine, and that is why there are no randomized trials in this sector or in this segment. That is what I honestly feel. It is difficult. I think if we put all our data of each one of us experience, and then you tell AI to come out with the plan B, plan A, plan C, and we can put it in the AI that this is the patient, this is what it is, this weight is this, obesity is this, blah, 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 comorbid this, and what is the best plan? Probably he will give an answer in 2 minutes or 3 minutes immediately, and at that time when you are in emergency.
Okay.
But for that, all of us has to put the data in it.
I think Pratima, that is one of the strength of the trial which you spoke about, the ECMO-CS trial, because they could actually randomize in those emergency situation and they could split to two groups. And generally in those emergency situation, it is very difficult to randomize.
Very
That's
difficult.
what is
Yeah.
actually the point made. Yeah, Dr. Munish, and
Correct.
are we done with the time or we can still take questions?
We are done with the time, but we are not done with the questions, at least I believe. It's a very interesting topic.
Dr. Munish, you wanted to?
Yeah, Dr. Manish, you want to say something?
No.
Okay. Okay,
So
Dr. Venkat.
Yeah, so we thank Dr. Pratima in bringing those three, one review paper and two randomized trial to actually create the discussion. I thank Dr. Rahul Pandit, Dr. Munish, and Dr. Arpan in bringing those experiences and the wisdom into the board. And we thank all the participants to being a part of it. And we conclude this session. I hand over to you,
Thank you.
Pratima.
Thank you, everyone.
Thank you.
Thank you so much. Thank you, Dr. Manish.